Please just make your final choices for food and sit down. We'll get started in just a few moments.
We stay seated.
Yes.
Yeah, we don't like that.
Just gotta make sure I can see this. Yeah.
Great. Well, good evening, everyone, and welcome to our program on enhancing patient care for CAR T-cell therapy and non-Hodgkin lymphoma. We're going to talk about comprehensive solutions for caring for patients across the board. I'm Dr. Christopher Flowers, professor and chair of the Department of Lymphoma and Myeloma at MD Anderson, and also division head for the Division of Cancer Medicine. And I'll let each of my colleagues introduce themselves, Dr. Coombs and Dr. Kaimi.
Hi, I'm Callie Coombs. I'm an associate clinical professor at the University of California, Irvine, where I focus on treating patients with CLL.
Good evening, I'm Paolo Caimi. I'm a staff physician at the Cleveland Clinic, and I also focus on the treatment of lymphoma and cell therapies for patients with lymphoma and lymphoma malignancies.
Great. And tonight's presentation will really be an interactive presentation where all of you in the audience will have a chance to choose among certain cases and pathways to the cases, and we'll spend the time with each of our experts answering questions and presenting data in response to the choices that you make. And so for those of you who have not had a chance to do it, please use this code, this QR code, to be able to fill out the pre-assessment. This also will be the same QR code that you use for those of you who are online and those in the room that are stationed at each of your tables to be able to perform the polling throughout the questions across the night and for the Q&A at the end of the session. So our educational objectives tonight are to be able to expand and address the treatment landscape for patients with non-Hodgkin lymphoma, including new options, including some that are just fresh, hot off the presses for CAR T options for patients, as well as non-CAR T options for patients, and to be able to analyze the available data, conduct comprehensive evaluation to determine the eligibility and options for individual patients, to be able to identify suitable candidates utilizing our cases, and to apply a multidisciplinary approach to management and coordination between referring physicians and outpatient CAR T centers. So just to start the polling off, please indicate what state you primarily practice. And our word cloud will lead you in the direction of where the largest number of individuals is. Looks like we've got a good showing from North Carolina here tonight. I think Dr. Coombs will be proud of that. Florida and Illinois here in the room. All right, and while folks give you a few more moments to finish voting. And then I think if you can give me back control of the slides, then I'll go on to the next question. So while the majority of this program will focus on CLL and mantle cell lymphoma from the cases that we focus on, I also wanted to give you some background on where we are across the non-Hodgkin lymphomas, where when we think about those in terms of diagnostic groups, we think of lymphoma as broadly being divided into Hodgkin lymphoma and non-Hodgkin's lymphomas, with the vast majority of those being the B-cell non-Hodgkin lymphomas. The most common and the most common form of aggressive lymphoma is diffuse large B-cell lymphoma. In the indolent conditions, those include follicular lymphoma and CLL, with CLL being the most prevalent of those, and then others that fall in between categories like mantle cell lymphoma. In thinking about the treatment guidelines for diffuse large B-cell lymphoma, as I'm sure all of you are familiar with, CAR T-cell is now moved up from being a third-line recommendation to a Category 1 recommendation in the second line for patients who have early relapse disease, less than 12 months from their primary diagnosis, or those patients who have primary refractory disease. And has been utilized in other settings for patients with relapsed and refractory diffuse large B-cell lymphoma. In follicular lymphoma, these are showing the treatment guidelines for patients using the National Comprehensive Cancer Center Network, or the NCCN. And you can see there at the bottom of the slide the recent approval of another CAR T, lisocabtagene maraleucel, for patients with follicular lymphoma that just came on May 15th. And that is something that's been used in the third line along with other approved CAR T-cell therapies in that setting as well. And while we won't talk about that in more detail here, have the opportunity to talk through that in the question and answer session if there are questions. And then when we think about the treatment guidelines for mantle cell lymphoma, there are a whole range of options that we'll talk through in the presentations today for preferred regimens in the relapsed and refractory setting, including the BTK inhibitors and other recommended options. But straight hot off the presses, as of yesterday, the FDA granted accelerated approval for lisocabtagene maraleucel CAR T-cell therapy, making that the second CAR T-cell approved for patients with relapsed mantle cell lymphoma. And then in terms of our treatment guidelines for CLL, we'll go through this in much more detail as we go through the cases. And the options for second and third line therapy include the BTK inhibitors, venetoclax and rituximab, and zanubrutinib, all as Category 1 recommendations, as well as a whole host of other therapies in the second and third line. And we'll talk a little bit about the role of CAR T-cells in this setting as well. So as we look across the range of approved CAR T-cell therapies, those are listed here: tisagen leclucel or Tisa-cel, exacabtagene ciloleucel or axi-cel, and lisocabtagene maraleucel, liso-cel, and then for patients with mantle cell lymphoma, brensocabtagene autoleucel, that we'll talk about in the remainder of the presentation today. We will address in the question and answer session some of the approved bispecific antibodies, if there are questions about those, including mosunetuzumab, glofitamab, and epcoritamab, that are now approved for diffuse large B-cell lymphoma and follicular lymphoma, respectively. And then one of the key things that we'll talk about through some of our discussions of the cases are the settings in the inpatient setting and the outpatient setting for the use of CAR T cells. So let's jump right into our cases, and this is the point where there's an opportunity for those of you who are online in the live stream of this, as well as those in the room, to make decisions about individual patients. The patient cards, for those of you who are in the room, are sitting right in front of you in terms of the patient cases that you'd like to select to move forward. So as part of this Build Your Own Case study, please use the QR codes that are in front of you and the descriptions of the cases that are sitting in front of you and the cards to be able to choose and build your own case study. So our set of cases are shown here. The first is Mr. Rosenstein, a 64-year-old fit gentleman from Maine, Ms. Blanchard, a 58-year-old fit woman from Utah, Mr. Campbell, an 81-year-old frail male from Iowa, and Ms. Souza, a 78-year-old woman who's frail, who's from Virginia. So our first case study will center around mantle cell lymphoma, including these two case studies. So first is Mr. Rosenstein, a 64-year-old gentleman from Mayo who has a past medical history of hypertension and prostate cancer. And you can see the description of his stage 2 mantle cell lymphoma and the characteristics that he had IGVH mutation, did not have TP53 performed at that time, and was SOX11 and negative. He underwent watchful waiting for approximately 2 years following his diagnosis, and then received bendamustine rituximab, followed by rituximab and cytarabine, or ARAC, and then had an autologous stem cell transplantation. And he now has relapse of his disease with the symptoms shown there. Those include hepatomegaly by palpitation, some GI involvement. His ECOG performance status, however, still remains 1. And then our second patient with mantle cell lymphoma is Ms. Souza, who's a 78-year-old woman with relapsed and refractory mantle cell lymphoma when she comes to see you. She has a history of a family member with ovarian cancer and a sister with breast cancer, was initially diagnosed with stage 3 mantle cell lymphoma, and you can see there the characteristics shown with her. She had a low proliferation index by Ki-67, and then at age 77, ultimately received initial induction therapy with rituximab and bendamustine, followed by maintenance therapy. Relapsed approximately 2 years after that and received ibrutinib, which she did not tolerate well, and now has symptoms of lymphadenopathy with bone pain, easy bruising and bleeding, and has expressed that she does not necessarily want aggressive therapy to proceed. So with those two patients in mind, we'll let you choose your patient that you want us to pursue moving forward. So as we wait for the responses to come in, Paulo, can you describe kind of how reflective these patients are of the kinds of mantle cell lymphoma patients you see in your practice?
So I think they're both different scenarios that you kind of tend to encounter in clinical practice. I mean, remember that mantle cell is a disease of relatively less young patients, meaning ages are around 67. So you will have a mixture of people who have comorbidities, who are not fully fit, and then you have a subgroup of people who do have some fitness. I'd say in terms of the disease biology, they probably represent the majority of relatively about 50% of patients who don't have a very aggressive form of the disease, but that requires treatment. The percentage of people who have a very indolent portion of the disease is very rare, and people who have a very aggressive version, like blastoid, is usually a little bit less than a third. In terms of their comorbidities, I'd say probably more patients are on the fitter side of things because of how our people in their 60s are getting to their 60s. But we still see a significant proportion of patients that cannot tolerate very aggressive therapies, for whom our initial treatment is relatively conservative, and we continue to be conservative throughout their care.
Thanks, Paulo. So it looks like from the folks in the room and those of you online that the majority would like for us to talk more about Mr. Rosenstein. So we'll follow that patient. So this is a 64-year-old fit gentleman with the characteristics that we described. We'll have to take things.
Treatment.
So moving next to the treatment choices for this particular patient, and as you think about those moving forward for this patient with relapsed and refractory mantle cell lymphoma, what sorts of treatment options would you like to select or to have us discuss for this patient? And you'll receive a poll through the link and see those votes there. So I think one of the treatment options here is a BTK inhibitor. And Callie, as you start to think about treatment options for a patient with a BTK inhibitor, what sort of characteristics do you think about are important for considering that in CLL or in any disease, and what kinds of things do you shy away from when you see in a patient?
Yeah, so I think BTK inhibitors are excellent drugs for a lot of B-cell malignancies. Specific to the patients that I see, of course, they're efficacious, but I always like to do a careful consideration of what this individual patient's comorbidities are, because that could inform potentially higher risk for certain toxicities. And so the main toxicities that I worry about, clearly cardiac is the most worrisome. Our second-generation drugs cause a lot less AFib and certainly much lower rates of severe ventricular arrhythmias than the first-in-class drug ibrutinib. I also really worry about risks for bleeding because all of the drugs can have kind of an antiplatelet effect due to both on and off-target effect on BTK, among other kinases. And so if patients are on dual antiplatelet therapy or, other anticoagulants, I avoid the use of these drugs in patients on warfarin. Otherwise, I don't see it as an absolute contraindication, but a reason to counsel the patients more on these potential risks.
Great. So it looks like the majority of you, perhaps following the recent news, are interested in CAR T-cell therapy for this patient. And so, Paulo, why don't you talk us through these data on brexacaptogene?
So these are the longest available data in terms of follow-up for a CAR T-cell product. This is brexacaptogene autoleucel, which is an it's an anti-CD19 CAR with a CD28 costimulatory signaling. This study included about 70 patients, the majority of whom went on to receive. These are the patients that ended up receiving the infusion. There's about 10% of patients that do not get to receive the infusion because they progress or don't progress before they can receive the treatment. Of the group, the response rate is about 90%. Overall response rate is about 90%. Complete response rate is on the high 70%. Interestingly enough, these patients have a duration of response of about 26 months with a progression-free survival of here to at the 25.8 months here, median progression-free survival. And the duration, again, for patients who have a complete response is very long, 48 months. If they achieve a complete response, a little much shorter on people who don't achieve complete response. Again, following the pattern that people who receive CAR T really having really a high response predicts very good outcomes, where not being refractory to them kind of significantly downgrades their outcome. In terms of, we can talk about later about safety, but I think this is the more established product in terms of duration of follow-up. The more recent data for lysocaptogene, we can probably come back to it if you want. We can talk about it now.
Maybe let's dive right into that. We don't have any slides on lysocaptogene maraleucel because it just got approved yesterday, and so that's quite hot off the presses. But maybe if you could describe your impressions of the data. And
I think the curves may not necessarily apply yet, but I think in terms of response rates, they're very comparable. Also high 80s compared to overall response rate. It's about high 80% compared to 90% for brexacaptogene, so very similar. And also the complete response rate is also very close to 70%. So very high rates of response rates in these patients. And in terms of safety comparability, lysocaptogene has about 60% of patients have cytokine release syndrome, but very small amount of patients have toxicities like neurotoxicity or cytokine release syndrome of high severity. So most of those toxicities were low grade.
And any thoughts about how those toxicities might be managed in patients, or we'll get to that in a little bit?
Yeah. But
So I think one of the other classes of agents that we think about, obviously, are the BTK inhibitors for relapsed mantle cell lymphoma. And maybe, Paolo, if you can walk us through pirtobrutinib and how you think about pirtobrutinib in this particular space.
pirtobrutinib is a non-covalent BTK inhibitor. It's probably it's a true second-generation BTK inhibitor. It's a drug that was tested in the Bruin study that included 90 patients in that part of the large phase 1/2 that included other histologies as well. And in this group of patients, about half of them were previously treated with another BTK inhibitor. Not all of them were resistant, some of them were intolerant, but some of the properties of these non-covalent inhibitors that it can overcome certain mutations like the C41S mutation of the BTK site, and it allows to overcome the resistance if their mutation is present, but also a specific property of non-covalent BTK inhibitors, particularly pirtobrutinib, is that the toxicity profile seems to be a little bit less intense than those of the covalent agents. Probably lower rates of AFib. It was in the single digit, I think 1.2% rate of AFib, and about less than 5% rate of bleeding. So in general, well-tolerated agents that allow sometimes to transition a patient that is intolerant of a BTK inhibitor or who has a mutation to a BTK inhibitor to receive a non-covalent with duration of response in the high 20 months, I think in the low 20 months, 21 months for people in complete remission.
Great. So you mentioned adverse events. Why don't we jump next to talk a little bit more about adverse events, and first hear some feedback from the audience. So which of these areas would you like to hear more about across the adverse events? Either the chemotherapeutic combination AEs, lenalidomide AEs, CAR T-cell therapy AEs, covalent BTK, non-covalent BTK AEs, BCL2 inhibitors, or allogeneic stem cell transplantation? So I think it's highly unlikely that someone's going to choose allogeneic stem cell transplantation, but maybe Paolo first and then Callie, while they're voting, can you just describe where you think allotransplant has a role for patients still with mantle cell and CLL?
I mean, there are still patients, there are still patients who relapse to CAR T-cell. We were talking earlier about whether everybody sustains a remission that's not 100%. So most people will eventually relapse after CAR T-cell therapy. They relapse after a non-covalent or a covalent BTK inhibitor. So even though the duration response is excellent, people still are refractory to the treatments and don't have other alternatives. Occasionally, I think the consideration is that if you're able to control their disease and achieve a robust partial remission or a complete remission in a patient with mantle cell lymphoma with a third or fourth line therapy, consideration for an allotransplant, which is replacing one disease with another, is something that you can do for a very fit patient, a patient that has a good donor, somebody that has the chance of having the follow-up for an allotransplant, with the consideration that it may be curative or if it's successful. So in general, I'd say it's still the last line of defense. I think in CLL probably a little bit less, but in very aggressive lymphomas, it has a very limited constrained role for the patient that has the capacity to tolerate it and has reached the point of fourth line in that condition.
And yeah, I almost never transplant patients with CLL. I definitely consider it in patients with Richter's who are in a good response to therapy, given that Richter's otherwise has a very poor outcome, but we can see long-term survival following allo, especially for the clonally related. The clonally unrelated can do okay with chemo. CLL almost never. We have so many novel agents that are so much better tolerated. I think the risk of transplant-related mortality is just very hard to justify, except for exceptionally rare cases of, my 30-something-year-old with CLL who's super refractory that has burned through everything. Yeah.
Completely agree with both of those. So it looks like the majority of the group would like to hear more about CAR T-cell therapy AEs. So Paulo, can you walk us through that for brexacaptogene?
So for CAR Ts in general and for brexucaptogene specifically, I think there's several immune-associated or immune-inflammatory-associated adverse events that are very particular to T-cell or immune effector cell therapy. Cytokine release syndrome is one of them, which is a syndrome that manifests itself with fever. We can have hypotension, multi-organ failure. That can get to be pretty severe. Most patients will have just fever, but you can have people with very people in the ICU intubated with hypoxemic respiratory failure. And then you have neurologic adverse events, which are usually a little bit later, with cytokine release happening usually in the first week. Neurologic events tend to happen later in the course of treatment, usually about 7 to 10 days after brexucaptogene, and usually it's manifested by an encephalopathy, but it can be a severe encephalopathy that gets to coma and seizures. Most patients treated with brexucaptogene tend to have a mild form of cytokine release syndrome. About 8% have a grade 3 or 4 cytokine release syndrome. Inverse to what you see in other CAR Ts, particularly for diffuse large B, the rate of neurologic events is more common with this treatment. It's about 30% of patients will have a grade 3, 4 neurologic events. And it's probably related to the biology of disease as well, but it may be also the fact that this is has a CD28 costimulatory domain that tend to be more inflammatory, more aggressive. For lysocaptogene, we don't have slides, but I think the lysocaptogene, the rate of cytokine release syndrome, as I mentioned, is about 60%. But most of the patients really only have fever. Maybe they'll have hypotension that is responsive to hydration. So in general, it's a grade 1, 2, very mild cytokine release syndrome with also neurologic events that are in the single digits. There are other adverse events for both that are important. There's hematologic toxicity that happens from the lymphodepletive chemotherapy. There are immune-mediated cytopenias that happen late after the treatment that we don't necessarily understand the mechanism yet very well. We think it's related to a baseline inflammation and activation of the cells, and those happen across the different CAR T cells in about 20 to 30% of patients. And really about management is really mostly coordinating with your team, predicting that they can happen, knowing that they happen in the first 2 weeks, but that these patients need to really be monitored throughout the first month, and they can't drive for 8 weeks. And the management is identifying them, giving them tocilizumab early for treatment of the cytokine release syndrome, using intravenous corticosteroids early for management of neurologic toxicity. We use prophylaxis for seizures, and we use support for intensive care as well.
Any particular notes that you want to pull out here in terms of the grades of toxicity as well as the use of steroids and toci?
I think that for cytokine release syndrome, the concept is really grade 1 is just fever, grade 2 an escalation of toxicity is just a more increasing support. So grade 3 and 4 are when you start using pressors and using mechanical ventilation, and really you escalate your level of intervention to just tocilizumab very early. We really are not waiting very long to start prescribing these medications for patients to kind of really break the cycle of inflammation, and then adding more agents, which can go all the way to corticosteroids and dexamethasone at mild doses of 10q12 to a big methylprednisolone pulse to patients.
And then what about for ICANS?
And I think the distinction to make for neurotoxicity is that when you have somebody who has neurotoxicity that is pure, that doesn't have cytokine release syndrome, tocilizumab doesn't have a role for treatment here. It's really corticosteroids and usually rapidly escalating to higher dose of steroids. And again, knowing that any encephalopathy, and usually the person that will identify the encephalopathy earliest is the patient's family, and they'll tell you they're a little bit loopier than normal, particularly for men. But usually it's being very proactive about monitoring these patients, the need to get the grading, and also the moment they start having some degree of dysfunction, so either grade 2, when they're having an encephalopathy that's affecting their mentation or their simple calculations, starting corticosteroids.
Great. Yeah, I think really key distinctions that you've made here. I think one that we very commonly use is the role of doing serial testing, like I-score testing, to know when that encephalopathy is occurring, and making the distinction that tocilizumab has limited or no impact on the neurologic toxicity, but there can be an overlap between CRS and the neurotoxicity, and that's the place where tocilizumab plus steroids has its most important role. So perhaps quickly running through the BCL2 inhibitor AEs, which was, I think, the next most common choice. You want to say a little bit about venetoclax monotherapy for patients with mantle cell lymphoma?
So though it's not a very frequently prescribed agent for patients with mantle cell lymphoma, I think based on data that it's maybe a little bit smaller group of patients, more retrospective information, and a couple of early phase studies, I think the additional specific side effects of venetoclax, besides having the hematologic toxicity, which is relatively common, it's people can have some gastrointestinal dysfunction as well as some cough I've seen, and the risk of infections. One of the very specific adverse events that happens with venetoclax, and we'll talk about it probably with much more detail in CLL, is the risk of tumor lysis. And I think in mantle cell, that risk is fairly intense, and I think you have to be relatively cautious with prescribing venetoclax in these patients, and being very proactive about admitting these patients through their course of dose escalation. I think the ramp up is really critical in this scenario, and it's a group of patients that, at least in my practice, although I think other people tend to sometimes consider accelerating the ramp up, I almost never do. I'm always very cautious with this drug and this disease. Maybe when it's used in combination, you could be a little bit looser, but I don't think that's a very common scenario. So in general, it's really being very proactive. You can have hematologic toxicity as you have here, the gastrointestinal symptoms, the risk of infection, the hematologic toxicity. Primarily, I manage by decreasing the dose. I'm managing. The nice thing about the dosing of venetoclax is that it comes in 100 milligram pills, so you kind of can go up on the numbers easily, up and down, kind of titrate according to tolerability. Usually, it's going down. And only escalate if the patient is really improved or resolved.
Great. As we move on to the CLL cases, Kelly, any other tricks of the trade about managing dosing of venetoclax?
Yeah, I mean, I think one of the most common referrals that I've seen where I would add a little bit of wisdom is discontinuing venetoclax too early based on neutropenia. So neutropenia in CLL with venetoclax is extremely common, but I think if you're proactive about it, I don't think I've ever had to stop the venetoclax because of the neutropenia. I just do aggressive support with growth factor. I try not to do dose reductions early, but in patients with severe neutropenia, I will consider that down the road. There has been a little bit of data regarding dose reductions in CLL, and maybe patients don't do quite as well, but that data is imperfect. I think if someone's having severe neutropenia, then obviously you have to weigh the risk and benefit. But I would say my main pearl is, don't give up on the drug for neutropenia, especially if you haven't tried growth factor. That almost always solves the problem.
Great tips. So let's jump in next to our second case study, or CLL case study with two patients here. So the first is a 58-year-old woman, Ms. Blanchard, from Utah, who has relapsed and refractory CLL. She had no real significant medical history to begin with, and was diagnosed with CLL with a watch and wait approach. No evidence of deletion 17p or TP53 was unmutated. Or it should be IGVH was unmutated. She was a 54-year-old woman when she initially got started on ibrutinib and rituximab, and eventually progressed and then received venetoclax. Her disease was refractory to venetoclax, and currently is having night sweats, fatigue, and expressed the preferences that are listed there. Our second patient, Mr. Campbell, is an 81-year-old frail gentleman from Iowa who has a past medical history of hypertension, type 2 diabetes that was controlled with metformin. Previously had an enlarged prostate, but was determined to be benign on evaluation. He was diagnosed with an aggressive behaving CLL with TP53 mutation, TP53 deletion, and then the deletions of 17p and 11q as noted there. He relapsed approximately 6 months after his frontline therapy with bendamustine and rituximab, and then received acalabrutinib before becoming refractory approximately 2 years later. He now presents with lymphadenopathy, lymphocytosis, and anemia, as well as fever and rapid weight loss. So giving these two patient scenarios, we'll give you a chance to vote on which one of those two patients that you'd like us to proceed with, both you in the room and those online. And maybe, Callie, the same question that I asked Paolo, how reflective are these patients of the kinds of patients you see in your practice?
I think they're pretty reflective. I mean, I see a mix. So I think being at a referral center, I do see maybe more younger patients than the average community doctor. But I also see plenty of older patients. And so I think it's always important to kind of ask your patient, obviously, what his or her underlying comorbidities are, do an assessment of performance status, because I think that can inform us on how well they can tolerate our various therapies in addition to what their preferences are. I mean, CLL, they call it an embarrassment of riches. We have a ton of therapies that work really well and maybe not one single best therapy, at least speaking about the front line, and our choices get a little smaller in the relapse setting, but we still have plenty of options. So often no one right answer.
So let's see who you picked. It looks like the vast majority of individuals would like to go with patient A. And so if you could just pull up that slide for us, Ms. Blanchard. So let's go on to talk about her treatment, and you should have a poll in front of you as well to talk about which treatment options that you'd like to consider for this particular patient moving forward with the choices shown there. There we go. So while the votes are coming in, surprisingly, it looks like there are a handful of people that would consider the PI3 kinase inhibitors. But maybe, Callie, if you can just comment on when you consider PI3 kinase inhibitors now for patients with CLL and what role you think it plays with the treatment options that we currently have available.
It looks like the person changed their mind. Maybe they hit the wrong button. It's now down to 0%. Look, I have used them before, but not very often. I think, fortunately, we have other drugs that are better, especially from a safety profile. But, I think the efficacy of the PI3K is a bit questionable in kind of this type of patient. I think it's important to realize the registrational trials of not only Idela with rituximab, but also duvelisib completely excluded patients with prior covalent BTK inhibitors. And so I don't think we can expect the PFS that you saw from those registrational trials in patients that are now failed by another B-cell receptor pathway inhibitor. And looking at real-world data of, what happens after a patient progresses on a covalent BTK and goes to a PI3 kinase inhibitor, the PFS is like 4 to 5 months, which is pretty bad. And we also see these class effects of all these itises, whether it's colitis, pneumonitis, et cetera. So I almost never use them. I actually haven't used them in several years.
Okay. So I think the majority of our votes are in, and so it looks like there is interest here, as well as looking at CAR T-cell therapy for patients with CLL. And so, Callie, maybe you can walk us through the data here.
Yeah, and so lisocabtagene amiriluzole got approved for CLL in mid-March based on the results of this phase 1/2 Transcend CLL 004 study. There were two different study populations that were explored. One is the full study population, which was 88 patients that were efficacy evaluable, and then on the right was the primary efficacy analysis set, which was patients who had prior exposure to both a BTK inhibitor and venetoclax. However, that's not all that patients got. These were very heavily pretreated patients. I think the median prior lines of therapy was 4 or 5, so don't quote me, but very heavily pretreated. And so I think what we show is actually the most promising aspect of the data, which is that among patients that attain a response, they can have very long durability of the response. And this is especially the case for patients who attain a CR or a CRI, where with, a couple years of follow-up, there are almost no progressors in that full study population. And then on the right, in the primary efficacy analysis set, that line is flat. And so, of course, the median is nowhere near being reached. However, even among patients that get a PR, we are still seeing some degree of durability of the response. And so the median progression-free survival for the full study population is 24 months. However, it's a little bit shorter, well, a lot shorter for the primary efficacy analysis set, but it's a year. And so that's still way better than I think what we would have expected kind of, prior to the availability of some of our newer agents for this group of patients who I think represented a huge unmet need in CLL.
And CRI is a little bit of a nuanced factor in CLL. Can you walk us through kind of how you determine the patients in CR or has a CRI?
Yeah, I mean, the CLL response criteria are kind of a pain, but, to be in a CR, it's pretty strict criteria. So you have to have, normal lymphocytes, essentially. You have to have all of your lymph nodes under 1.5 centimeters. So there's a lot of patients who don't quite meet CR, and they're in a PR because they have like a, long, skinny lymph node because it's bidimensional measurements. But as far as the CRI question, CLL is a disease that involves the marrow, and we know lysocell, among other CAR T-cell products, can lead to prolonged cytopenias, and maybe it's a little worse in CLL patients who are often kind of beat up, but they also have disease that directly can cause the cytopenias by the degree of marrow involvement, let alone the fact that some CAR Ts can lead to delayed cytopenias as well due to the conditioning products. So CRI is just for patients that otherwise meet these, pretty strict CR criteria that I mentioned, but don't quite have complete count recovery.
So maybe just walking through the other choices here, Callie, what kind of other choices would you consider for a patient like this, and which of those would you like to walk through next?
Yeah, I think the second most popular answer was pirtobrutinib. I would say that would be my main go-to unless a clinical trial was an option. Of course, I'd put someone on a trial, but, let's not choose that because that's kind of always the right answer if you want to choose it. And here, of course, no right answer, but I think I'd discuss pirtobrutinib with her as well. And so the data to support the use of pirtobrutinib is based on the same Bruin trial that Paolo mentioned. However, because CLL is a more common malignancy, we were able to accrue a lot more patients with CLL, SLL in this study. So the entire study population was almost 800 patients, but CLL was maybe around 300. And then when we specifically look at the double refractory patients, that was like 100 or so. So I think the very promising thing about pirtobrutinib that makes it attractive for certain patients is that it is, number one, very tolerable. So the rates of high-grade toxicities are very low, and there's a very low rate of discontinuation due to adverse events. The other reason that it's an attractive therapy for many patients is it also has an high overall response rate, around 80%, even for the double refractory or double exposed patients, meaning those failed by the covalent BTKI, but also venetoclax. So I think the downside, which, is maybe why CAR T would be particularly attractive for this young fit patient, is pirto just doesn't last forever. And so among patients who are in this double exposed, double refractory group, which is the basis for the FDA accelerated approval, the median PFS is about 16 months. And so for an 80-year-old, that's pretty good. A safe drug that's going to work most of the time, get me another year and a half, awesome. But for a really young patient, this is not going to be the end-all be-all. And so I think that's where CAR T, which has the potential for, a durable response in a subset of patients is, maybe, a bit more attractive. But neither of these are wrong in my mind, and I would honestly discuss both options with this patient.
And these data from Anthony Mato's study show us kind of the use of Perto after CAR T. Any data or personal experience with CAR T after Perto and ways of thinking about that?
Yeah, I actually did put one patient on this study that had failed CAR T. He was on one of the early MSK CAR T trials for CLL. He'd traveled up to New York, came on Bruin, and he had a beautiful response. But he was very young, and so he's actually one of the few patients I transplanted because he was so young, his goal was always transplant. So I think I was one of the very few investigators that transplanted anybody on Bruin. But that one of them was mine, and he'd failed, chemo, ibrutinib, venetoclax, CAR T, and then, he was responding to Perto, and we used that as a bridge to transplant, given that that was always his long-term goal, and I think it was reasonable. I think he was like 50-something.
I think one of the other treatment options that this patient had already received that commonly comes up is the role of the BCL2 inhibitors. Do you use those alone or in combination, or how do you think through the use of those?
Yeah, I mean, most patients I use venetoclax in combination. Of course you can use it as a monotherapy. That was based on the original approval to use just ven continuously. But I think the real beauty of venetoclax is to use it as a time-limited regimen. And so in the relapse setting, the technical label for venetoclax is with rituximab. Many of us, kind of CLL doctors will swap out obinutuzumab, and that's based on the fact that obin is the superior antibody, but that is extrapolating from frontline data, so sometimes insurance won't pay, and then if they don't, that's, kind of fine because ven with rituximab also works very well. And so these are the data to support ven with rituximab, specifically the Murano trial, a very good trial. It compared ven-R with BR, so both time-limited regimens. The ven is given over 2 years with 6 cycles of rituximab, and the BR is the standard 6 cycles. And I mean, this is such an impressive PFS advantage, kind of telling me never to use BR in the relapse setting if a patient hasn't seen ven. Unique to this patient case, though, is she actually was refractory to ven. That's not that common, but I can think of a few patients who have been refractory. And so, she's done with venetoclax because it has failed her. However, I certainly would think about retreating patients with venetoclax if they had a good response and it was, some degree of durable, which most of us say 2 years, but longer is always better. I always think about retreating with ven, but that would not have been appropriate in her case for the reasons I stated.
Right. Okay. Sure. If you,
Are these them?
Yep.
They're on the screen.
Okay. Oh, perfect. So the first question is about bispecific antibody treatment. How do you think about that fitting into the landscape? Maybe we'll start with Paolo here in relapsed mantle cell lymphoma.
So I think certainly these are active agents across. Mike? There we go. Is it better?
Yeah.
Yeah, without a mic, it's not going to happen. Certainly these are agents that are active across different subtypes of lymphoma. They're approved in diffuse large B. There's bosunotumab approved in follicular lymphoma. In mantle cell lymphoma, they have activity, although they have seen or we've encountered a little bit more rates of cytokine release syndrome, in part because of more circulating disease and there may be more inflammation through this patient. So I think they probably will reach at some point approvals. I just don't know whether they're going to do that in combination with a different dose ramp up. I think the safety profile needs to be a little bit more better characterized for the class before we start seeing approval. I think compared with CAR Ts, they have different characteristics. They have a lower rate of cytokine release syndrome, maybe actually not as. When you compare with lysocell, it may be a little bit more comparable, but they're off the shelf, relatively off the shelf, and their logistics are different, right? So they require some hospitalization, but it's not as long. So I think they probably will have a role, but I think the bigger takeaway is that particularly mantle cell, they're not ready to be used because we need to figure out a little bit better how the safety profile of these agents is.
Right. And we said at the outset that we would talk about things other than just mantle cell lymphoma. You mentioned bispecifics and follicular lymphoma. What about in diffuse large B-cell lymphoma?
I think in diffuse large B-cell, I think it's a question that we all have is, is the duration of response and the potential for cure that we see with CAR-T in significant proportions, not everybody in a significant proportion of patients, can that be matched by different T-cell redirecting therapies like the bispecifics? And I think that requires longer follow-up. I think we think that possibly with, particularly with those that are term limited, you may be able to cure some patients with diffuse large B-cell lymphoma, which in general is just really the ultimate goal in that type of disease. But the question is probably that they perform a little bit less well in terms of long-term duration of response than CAR-T. So I think they're easier drugs to give, but they're probably a little bit less active than CAR-T and diffuse large B-cell lymphoma.
Yeah, I would completely agree with you in those comments. I think, we can only cure patients with time-limited therapy, and so unless the therapy is time-limited, we can't evaluate the potential for cure, and we need longer follow-up, at least 2-year follow-up with PFS, and ideally 5-year follow-up. And so once we start to see those with bispecifics, with time-limited therapy, then we'll know how those might compare a little bit better. And then maybe staying with diffuse large B-cell lymphoma, then perhaps touching on mantle cell and then CLL, what about moving CAR-T to the frontline treatment with multiple agents that are moving that direction?
So in the diffuse large B-cell side of things, I think there's a large, there's based on ZUMA-12, which was a trial evaluating the use of CAR-T in people with highest risk for primary refractory to initial therapy after a couple cycles of treatment. There's ZUMA-23, which is something with axicabtagene ciloleucel, looking at the use of axicel or CAR-T for patients with the highest of IPI, so 4 or 5. These are usually patients who are probably visibly sick from their lymphoma, and I think that study will read out. The question is, are those patients that would otherwise still have gotten CAR-T because it would progress after initial therapy? Is that going to really increase the patient population that is treated with CAR-T? I'm not sure out of that trial. I think logistically, increasing the number of people receiving CAR-T and giving it for many patients in frontline will take a while, if it will happen at all. I think it's a little bit of struggle in terms of how many patients can our capacity reach, and how many patients can travel the distance if they can be cured with something a little bit simpler, possibly as toxic or less toxic than CAR-Ts if it's a combination of novel agents plus chemotherapy.
And Callie, any thoughts about moving CAR-T in the front line for CLL now or ever?
I mean, that would be a very bold study. Look, it's a very intriguing option. I think it would be challenging just because of how many other very effective frontline therapies we have. So I don't see it anytime soon, but I think it would be interesting to see it in less refractory patients because I would expect the efficacy to improve if we get patients who are maybe third line as opposed to fifth, sixth line.
Yeah. Any particular high-risk patient populations like the 17P and TP53 populations that?
Yeah, I think that would be a population I'd love to see more data on CAR-T. I mean, I think one of the really nice things about CAR-T is it doesn't seem to discriminate on its efficacy based on these high-risk markers. I think there is an oral at EHA coming up looking for predictors of response to CAR-T, and having lower tumor bulk is promising, and so maybe also kind of applying it more as even a consolidation type approach, I think might be intriguing. So I think there's certainly a lot of ways to kind of maneuver it maybe in earlier lines, but focus in on these highest risk patients who are more likely to be failed by all of our existing therapies as opposed to the ones that are going to do just totally fine with venetoclax and covalent BTKI over their remaining lifespan.
Yeah. Great answer. So if there are other questions that are coming in from the audience or from the room, please pop those up and we will jump in with those. Otherwise, perhaps let's think about some of the treatment options that might be possible for our older patient, Mr. Campbell. And so any of those that you might think about differently for that particular patient in the relapse setting?
I don't remember his history, but was he double refractory?
Well, I think one of the things that was a characteristic of him was that he was, yes, refractory to BTK. But how would you think about the use of BTKs in the relapse setting for an older patient in general?
Yeah, I mean, of course, you have to consider what was the reason that the patient, if they've had a BTK before, what was the reason that the patient stopped it? And so if it was an intolerance issue, which comes up literally like every clinic I have is some type of intolerance. It's less now that we're using more Acala and Xanu. Intolerance, I certainly think about just switching them to one of our, kind of second generation drugs, Acala, Xanu. If they progress, then it's really not appropriate to switch them because of the shared mechanism of resistance. And so my usual go-to in that setting is venetoclax. I mean, it's kind of our main FDA-approved option with mature data from largely the Murano trial, but obviously realize very few patients in Murano were post-BTKI. There was a separate phase 2 that looked at the use of venetoclax after ibrutinib specifically, but it was this paper that it was used as a continuous monotherapy. So Perto actually has very strong data after covalent BTKI from the Bruin trial. It's listed in that way in the NCCN guidelines, but that's not fitting with its current FDA label where it should be patients failed by covalent and venetoclax. So with an older patient, it kind of depends on their individual situation. If he has good transportation to and from clinic, if he progressed on a covalent BTKI, I'd probably go for venetoclax. If he can do the ramp up, I'd do it with my CD20 of choice, depending on what his insurance pays for. But, I think in the third line setting is where, kind of these other options are especially relevant. And we've obviously spoken about pirtobrutinib, which is, I'd say, the mainstay for someone who's old and a bit more frail in the third line setting, should he reach that.
Great. Well, let's go back to all of you, both in the room and online, to get a chance to vote about what you want to hear about in CLL safety by drug class in terms of the AEs, and we'll see your votes coming in. I don't see the votes coming in directly, but maybe if you'll pull back to the slide, given our, if you'll pull back to my slides for me. There we go. So it looks like CAR T-cell therapy is leading the day.
I mean, that was the name of tonight's program. But yeah, I think
Perhaps
it's a good thing to talk about.
Yeah, perhaps you'll pull back to my slides. Callie, I'll let you talk about the AEs associated with CAR T-cells in the setting of CLL.
Right, yeah, so we've heard a lot about the toxicity of Brexucell and also Lysocell in the setting of mantle cell lymphoma. CLL obviously is maybe a bit different of a patient population, maybe a little older. Obviously, you can, appreciate that they've had a number of different lines of therapy and also this underlying kind of immune suppressed state by virtue of the CLL itself and all their prior therapies. The main kind of worrisome side effects that we always think about with CAR T, of course, are cytokine release syndrome and then these neurologic events. I think the key message is, there is a high degree of cytokine release. It was seen in 85% of the full study population. However, most of it's grade 1 and grade 2. And so fortunately, the grade 3 and higher events are very uncommon. So there were actually no grade 4 or 5 events, but 9% of patients had grade 3 events. I think it's important to realize the time of onset too. And so for the CRS, this happens about 4 days from the therapy, and then time to resolution is 6 days. And I think that's meaningful for patients because if they're kind of in the throes of an episode or, to educate their families, kind of letting them know, well, this is what to expect of how long this will last, which can maybe help them, see the light at the end of the tunnel. Neurologic events can also be seen, and though the total incidence isn't as common, total is 45%. The grade 3s end up being a little bit more numerically common, so those occur in 18% of patients, and then grade 4 in 1% of patients. The time to onset is usually a little bit later, 7 days, and then the time to resolution is 7 days. So of course, these aren't the only therapies. I think the delayed count recovery is something, of course, to consider. And many of these patients may have had cytopenias going into the therapy, and likely following the conditioning. This can be persistent among a significant proportion. And I think supportive measures are always just important to consider. In addition to that, there are some rare immune-mediated pancytopenias noted, and then B-cell aplasia. So some patients may necessitate IVIG if they didn't already before. That could be a new need as well.
Great. Well, as we move to wrap up the program, perhaps we'll talk through some of the key misperceptions regarding CAR T-cell therapy. I think the first is that, I think as both of you have pointed out, both for CLL and for mantle cell lymphoma, this really should not be a last resort and something that should be explored earlier, particularly for patients who have high-risk disease. That those toxicities, as you just described for CLL, and as Paulo described earlier, are ones that can be typically managed in the post-acute setting at the CAR T center, and that our long-term follow-up is required, but it's not quite as extensive as we've talked about in other programs, and can be managed both with the referring center and with the CAR T center where the patient is seen. And there are lots of types of support, both in terms of the insurance status support, as well as support services to address emotional, financial, and logistic concerns. And as we start to think about the multidisciplinary approach that's needed, really there are a number of factors interprofessionally that can occur in collaborations between academic centers like ours and community oncologists, both in terms of providing patient education, ensuring that there's timely intake and appropriate referrals for patients with CAR T across the board in follicular, diffuse large B-cell lymphoma, mantle cell, and CLL, assessing the patient and caregivers' needs, and being able to recognize and monitor the adverse events that you described today to be able to assist with patient logistics throughout the CAR T process. And increasingly, I think it's important that patients participate in clinical trials. I think the trials that we described here today around CAR T are ones that led to the approvals, including approvals as recently as yesterday for CAR T therapy. But there's definitely a need across the United States to increase the diversity of enrollment on those clinical trials to address barriers that are shown there, like mistrust, trial availability, and patient access, and to have specific solutions that help to address each of those barriers. And there are a number of ongoing and emerging therapeutic options, including numerous additional CAR Ts, such as opportunities like dual targeting CARs that we'll see coming forward in trials moving forward, new and improved autologous CARs with alternative strategies, allogeneic or off-the-shelf CARs, and moving CAR T-cell therapy earlier, as we've discussed about, as well as combinations and single new agents like the CELMoDs, BCL2 antagonists, and other novel therapies like PROTACs. So to jump into our post-test assessments, you can also answer those both online and for those in the room through the same link. So our first patient is a 62-year-old gentleman with mantle cell lymphoma who's received multiple lines of therapy, including chemotherapy plus rituximab and ibrutinib, followed by pirtobrutinib. And despite these treatment options, his disease has progressed. He doesn't have any comorbidities and is otherwise in good health. What kinds of therapeutic strategies would you think about next? Immediate CAR T-cell therapy in an inpatient or outpatient setting, CAR T-cell after additional salvage therapy, chemo followed by auto transplant, and immediate treatment with a second-generation BTKI followed by CAR T. And remind me, are you going to show the results of the poll? No. Okay. So Maybe as we think through this, Paulo, for someone with mantle cell lymphoma, why would you think about immediate CAR T for this particular patient?
Again, Tony, I think one of the things that you have to consider is what the patient's received in the past. I think a patient that's already having disease that seems to be progressing both through a covalent and a non-covalent BTK inhibitor really doesn't have a significant, I wouldn't expect that he has a very significant chance of responding to another BTK inhibitor. You could use chemotherapy to bridge him to the CAR Ts, but usually if they progress to a prior chemo, you would think that this is a highly refractory patient. I think one point to make here is that a patient that is progressing on pirtobrutinib, which seems to be that, or has disease progression after pirtobrutinib, is somebody who might continue the pirtobrutinib up to the day he gets the CAR Ts close to, because if you actually remove the BTK inhibition, they tend to flare and tend to have rapid progression of disease, and actually sometimes can get very sick to the point when they get their CAR T. So in general, this is a patient that I will maybe hold the pirtobrutinib for apheresis and then restart it after manufacture. And that would be probably what I would attempt, to just continue the pirto, hoping for the best, maybe consider some bridging in between, and then give them the CAR Ts as soon as possible.
Okay. Well, in the interest of time, we'll run through our next three post-test questions. So the next is Mr. S, who's a 64-year-old, Ms. S, who's a 64-year-old woman with relapsed and refractory CLL, who received a BTK inhibitor and a BCL2 inhibitor, who's relapsed, has hypertension, type 2 diabetes, and the following are their potential treatment options moving forward. We'll give you an opportunity to vote. Okay. Maybe on to the next question. So our patient number three is question number three is patients with CLL treated with lisocabtagene maraleucel on Transcend. What was the incidence of grade 3 or higher cytokine release syndrome and grade 3 or higher neurologic events, respectively? And the choices are shown there. Okay, and the correct choice for that is D, so CRS rates of 8% and neurologic events of 19%. And for our final question, Mr. R is a patient with mantle cell lymphoma who has stage 4 disease with extranodal gastrointestinal involvement with P53 wild type, initially treated with anthracycline and cytarabine chemoimmunotherapy followed by auto transplant. 3 years later, he has relapse of disease with systemic symptoms. Biopsy confirms relapsed mantle cell lymphoma, and you discuss treatment options, including the following below for this particular patient.
Oh, there's two Bs.
Well, hopefully B is the correct answer then.
Increase your odds.
All right, and we'll go, and if you can pull up the poll. I think we're back one question.
The right answer, it's just wrong.
Okay, wrong question. Okay, so yes, B is the correct answer here. All right, next slide. And so just to wrap up, really, the treatment landscape for non-Hodgkin lymphoma is rapidly expanding, include various CAR T-cell therapies, including ones that were approved, two that were approvals just earlier this month. And engaging patients in shared decision-making really is critical, as you heard about through the discussions today. Hopefully this led you to believe that there's a true need for a multidisciplinary approach between our referring physicians and outpatient community centers to be able to address the variety of treatment modalities that continue to evolve. There will be additional assessments and evaluations that are available to you online afterwards, and I thank you all for your time and attention, for those who attended in the room and those who attended online. And to claim your credits, please use this QR code to be able to answer those post-test survey questions. So thanks, everyone.
Good job with the slides.
Wow.
See you sweating a little when it was going